not a clinician, but I am very privileged to be able to give you this update on behalf of all of these amazing clinicians. So Sunil Lakhani is the lead of our Q-IMPROvE project, which is to implement, even if in the short term, as we're an innovation project, but implement precision oncology in breast cancer in Queensland. So what we've done is sort of similar to what Professor North was alluding to earlier, was link as many people together as we can to increase our kind of power and cohort size. So we have a number of representatives from Metro North and the Royal, so Owen, Ben, Poe, we've got Pete Simpson from UQCCR. We have Metro South covered with Ken O'Byrne and Ewan Walpole. We have Nicole McCarthy at Outcon and the Wesley, and we also have a team from the MARTA on board. And together we've worked out the project so that it would suit all sites as well as we can. And we're going to really offer the service across Brisbane and then see where else we can take it. So the problem is this: when we talk about cancer often being highly heterogeneous, breast cancer is really the number one focus of that. It's incredibly heterogeneous. We talk about it as though it's one disease, but really it's hundreds. Our current predictive biomarkers are relatively limited to ERPR and HER2, and while they do work well in a number of patients, we could really do a lot better. If we treat patients adjuvantly, then we would need to follow them up for a very long time in order to determine whether novel biomarkers or therapies are working. And finally, as we move forward in the post-genomics era, genomics and whole genome sequencing, in particular of breast cancer, is becoming increasingly relevant. We're finding new treatment options based on predictive biomarkers, including signature-based biomarkers, and also we're increasingly able to consider repurposing therapies for other cancers back to breast cancer. So the solution that we propose is to implement a whole genome sequencing pipeline to inform therapeutic decisions in breast cancer. We've chosen the neoadjuvant therapy setting as it offers us the possibility of almost performing an in vivo experiment to determine biological response to different therapies. Now, we'll find that about 60 to 70% of patients will have a pathological complete response. So in around 40% of patients, we're not sure what the best second-line therapy would be, and this is where the whole genome sequencing data can inform what to do there. We would do the sequencing from a core needle biopsy, and then we'll use this data to inform the management for those patients after taking it through the cancer advisory panel or a molecular tumour board, implementing that through the MDT, and the patient's physician will have the final choice as to how we move forward with therapy. So the most important thing about this being an innovation study, and even if it is kind of an implementation, is that we're not altering first-line standard of care. So the potential benefits and outcomes here are, firstly, that we would establish pipelines for doing this in breast cancer in Queensland. Then patients are going to benefit from having an informed second-line therapy decision made and potentially be triaged to relevant clinical trials. There's going to be an economic benefit in that we will reduce ineffective drug prescriptions. And once the pipeline is established, we really hope to roll this out statewide. The pipeline in the future is likely to benefit a lot of other cancer types. As more data comes on for these specific cancers, we'll be able to see how well that would apply for the whole genome pipeline. So in terms of a patient cohort and who would benefit, obviously neoadjuvantly treated breast cancer patients and their families would benefit from this. In future, we think that perhaps there would be a role for whole genome sequencing in adjuvantly treated breast cancer patients. But ultimately, as we have linked a large number of big hospitals across Brisbane and hopefully throughout the state, we are really getting a cohort size here that will really put us on the international stage. So how does it work? The operations, from diagnosis and through early biomarker testing, a patient will be triaged towards neoadjuvant therapy. At the time that they have a staging scan or have a marker clip inserted, we would take extra core needle biopsies then, and that would be sequenced. We'll also take some blood then too. And then the patient would start their neoadjuvant therapy and have however many cycles is required. In some patients, I'll stop there and just say that we would be sequencing the sample in parallel as the patient's undergoing their neoadjuvant therapy regime. We anticipate that the data would be back within 4 to 6 weeks, ready to go through an MDT or through the Cancer Advisory Panel. In some patients, we have a second staging scan after about the second or third cycle of neoadjuvant chemotherapy. If this is the case, and if there is still sufficient tumour left, we would like to take a biopsy there and also some blood samples. At the end of the study, there would, of course, be breast imaging and then surgery if necessary, in which case we would again take tissue if there was any surplus to diagnosis. And it is at this point that the whole genome sequencing will really inform how to move forward. So we'll be able to determine what the best second line of therapy might be, and also whether that patient could benefit from clinical trials. So to give you an example of the kind of therapies we might consider, using signature-based analysis, we can now determine if a patient has a functional BRCA1 or 2 defect. In patients lacking these proteins, they are often sensitive to platinum-based chemotherapies and also sensitive to PARP inhibition, so it might be useful to try olaparib in these patients. Equally, we would be able to get a really good read on the tumour mutation burden, and therefore perhaps consider pembrolizumab or other PD-1, PD-L1 based therapies, and even other just broader immunotherapies.